Hello, all of you. Hello, everyone. Hello, all of you. Please wait. Hello, everyone. Welcome to a discussion of second part of FMGE Accelerate series in biochemistry. So please give me a thumbs up if everything is okay. Yes, please. Yes. Medico Ultra. Ram Ram, sir. Ram Ram. Sannyasi Pandit. So this is the revision type of video. Okay. Hello, Sannyasi Pandit. Please give me a thumbs up if everything is okay. I am audible and visible to you. If I am audible and visible to you. Yes, I will check that. Yes, anyone? Please give me a thumbs up. Yes, sir, all fine. Medico Ultra. Thank you. So today we will start the session FMG Accelerate series. Okay. In this part, we'll focus on the acid-base disorder. Then we will focus on the lipoproteinemias, different lipoproteinemias. Good evening, Akhil. Then we'll discuss the relation between vitamin C, collagen, copper, glycine. Vitamin C, collagen, copper, glycine. So we'll discuss that. See, today we will discuss vitamin C, and along with the vitamin C, we'll discuss vitamin C. We'll discuss the collagen. All of you know that vitamin C is required for the collagen formation. Then audible and visible, sir. Thank you, Mohit. So we'll discuss about the vitamin C. We'll discuss the collagen. We'll discuss about the copper. We'll discuss about the glycine related with this. Okay, so they are interrelated with each other. They are interrelated with each other. Then we will discuss about important glycosaminoglycans. Glycosaminoglycans, which is part of extracellular matrix. Collagen is also a part of extracellular matrix. Glycosaminoglycan, they are part of proteoglycans. So glycosaminoglycans we will discuss. Then we'll discuss some important PYQs related with the genetic topic. Then we'll discuss hyperlipoproteinemias. Hyperlipoproteinemias. Glycogen storage disorders. And some important PYQs related with the FMGE exam. So we'll start with the session. So in this session, starting with the first MCQ, the last yesterday's topic, that is the acid-base balance. This is a conceptual topic. So required understanding, acid-base balance. Okay. A 49-year-old lady admitted in medicine ward. It is admitted in medicine ward with complaints of chronic obstructive airway disease. COPD, chronic obstructive airway disease. Since years. On examination, she was found cyanosed and breathless. Blood investigation reveals pH 7.21, PCO2 65, and bicarbonate 34 millimole per liter. Name the disorder. Now, how will you proceed for the acid-base disorder? So first see for the pH, whether it is acidic or basic. So you know the normal range 7.35 to 7.45. This is the normal range of pH. If it is below this, it is acidosis. And if it is above this, it is alkalosis. Now see here, it is acidosis or alkalosis 7.21. Yes, it is acidosis. Then see PCO2, it is 65. 65 indicates acidosis or alkalosis. 65 means carbonic acid. Compare this PCO2, partial pressure of CO2, with the carbonic acid. So it is acid. Acid increases. It means it is respiratory acidosis. Now see for the bicarbonate, 34. The normal range of bicarbonate is 22 to 28 millimole per liter. If base increases, it is alkalosis. If base decreases, it is acidosis, and that is metabolic. This is metabolic component. What does it indicate? This CO2, partial pressure of CO2, is the respiratory component. This is metabolic component. This will indicate metabolic. 34 means alkalosis. So this is acidosis, means primary defect. Primary defects, those parameter which will go with the pH, is the primary defect. So here is the acidosis, here is the acidosis. So primary defect is respiratory acidosis along with compensation. So here answer is answer B, Shubham. Answer B, correct answer. It is respiratory acidosis with compensation. Okay, respiratory acidosis with compensation. See the second example, it is a classical case. Okay, it is frequently asked in the exam. This is the positive Benedict test, this is the positive Rothras test. Benedict test, brick red color and purple ring at the junction of two solution in the Rothras test. We'll discuss that. First we'll discuss the question. A 17-year-old boy, see, it is 17-year, this is important, young boy, diagnosed with diabetes, brought to the hospital in semi-conscious state and abnormal deep rapid breathing. His plasma glucose 673 milligram per deciliter. Urine shows positive Benedict and Rothras test. This is positive Benedict test, positive Rothras test. Blood investigations reveal following result: pH 7.21, PCO2 30 and bicarbonate 60. Name the disorder. So there is confusing thing and compensation as well. Yes, but here what is answer? This is a typical case when there is excretion of glucose and ketone bodies in the urine. There are 3 to 4 conditions in which ketone bodies are positive in the urine. The first is uncontrolled diabetes mellitus or diabetic ketoacidosis. This is the first cause. Second is the starvation. In the starvation condition, there is increased ketone body excretion in the urine. And third is that branch chain ketoacid urea, means maple syrup urine disease. In these 3 conditions, there is excretion of ketone body in urine. But remember, in the starvation, the glucose will be negative. In the starvation and the maple syrup urine disease, this will be negative. Okay, Benedict test will be negative. So it is a typical case of diabetic ketoacidosis, because the young patient, young adult, means insulin dependent diabetes mellitus. The most common complication in insulin dependent diabetes mellitus is diabetic ketoacidosis, semi-conscious state and abnormal rapid breathing. This is the Kussmaul respiration. It is also known as Kussmaul respiration. What is the meaning of this? Kussmaul breathing. What is the meaning of this? Deep and rapid breathing. That is known as Kussmaul breathing, and it is compensatory mechanism. This is metabolic acidosis compensated by respiratory mechanism. Respiratory mechanism, these are the short-term mechanism to compensate metabolic component. Okay. Now, what is the here there is no diabetic ketoacidosis. Now see for the pH. 7.21 means acidosis. Okay. Bicarbonate 16 means it is less than 22. It is metabolic acidosis, means this is primary defect. The parameter which goes with the pH is the primary defect. Second one is the PCO2. Normal range is 35 to 45. So here is decrease in carbonic acid means alkalosis, that is respiratory alkalosis. So this is compensatory mechanism. This is compensatory mechanism. Okay, so it is a case of metabolic acidosis with compensation. But there is no option of compensation, so we will go with the metabolic acidosis. This is only confusion, to create the confusion. Okay, so as pH is 7.21, this is, you should cross this first. If pH is 2.71, if it is below 7.35, then cross the alkalosis causes first. Then only two options will be left. Okay. Now this is Benedict test, this is Rothra's test. What is the use of Benedict test? Benedict's test. It is for reducing sugar in the urine. Reducing sugars. Reducing sugars are mainly monosaccharides and some disaccharides gives this test positive. Monosaccharide, fructose, glucose, galactose, this gives this test positive. Then lactose, maltose, disaccharide gives this test positive. Sucrose and trehalose do not give the Benedict test positive. They are non-reducing disaccharides. So disaccharide, reducing disaccharides, it includes the maltose and lactose. And non-reducing, it includes sucrose and trehalose. Why they are non-trehalose? Why they are non-reducing? Sucrose, though it is made up of glucose plus fructose, it is non-reducing sugar. Both glucose and fructose, they are reducing. Trehalose, it is made up of two molecules of glucose. And it is made up of two molecules of glucose and it is non-reducing. Why? The reducing property is because of the free functional group which is present in the monosaccharide or disaccharide. Sucrose, it is made up of alpha 1 beta 2 glycosidic linkage. The functional group in glucose, it at the C1 position, and at fructose it is at the C2 position. So both the functional groups, they are involved in the bond formation. So that's why the sucrose is non-reducing sugar. Trehalose, glucose C1 C1 linkage. Here is C1 C1 glycosidic linkage, means alpha 1 alpha 1. So both the carbon, C1 carbon, both the functional group, they are involved in the bond formation. That's why it is a non-reducing sugar. So sucrose and trehalose, they are non-reducing sugar, while rest of the monosaccharides and lactose, maltose, they are reducing. Okay, having the reducing property. So Benedict test, there is play of color from green, yellow, orange, red and brick red, and depending upon the color form, it will tell about the approximate percent of the sugar present in the particular solution or urine solution. If it is green, it indicates the 0.5 gram percent. It is roughly, okay, it is not exact. Yellow 1 gram percent, orange 1.5 gram percent, red it is 2 gram percent, and brick red it is more than 2 gram percent. So that's why this test is known as semi-quantitative test. This test is known as semi-quantitative test. Now coming to the second test discussion, that is Rothra's test. These are the very, very important tests, these two. Rothra's test. Rothra's test. It is given by two ketone bodies. One is the acetone and acetoacetate. But it is not given by the predominant ketone body, that is, it is not given by beta hydroxybutyrate, which is a most common ketone body in diabetic ketoacidosis or starvation. Which one is the most common ketone body? This one. But this will not give the Rothera's test positive because it does not contain true keto group. It contains hydroxyl group. Okay, it does not contain true keto group. These acetone and acetoacetate contain ketone group, but it is synthesized from acetoacetate. That's why it is included in the ketone bodies. Ketone body. So this is the primary ketone body. Acetoacetate is the primary ketone body. Acetone and beta hydroxybutyrate, they are secondary ketone body. To give this beta hydroxybutyrate test positive, the one test is available that is known as modified Rothera's test. It is known as modified Rothera's test. In that, the beta hydroxy dehydrogenase enzyme is added, and that will convert this beta hydroxybutyrate into acetoacetate, and then acetoacetate will give this test positive. So this is the most common ketone body. This one is the primary ketone body. Acetone and beta hydroxybutyrate, they are secondary ketone body. The ketone bodies, they are important source of energy in the starvation and prolonged starvation, particularly for brain. During the starvation and prolonged starvation period, it is an important source of energy. And one more important, which is important in ketone body, it is not utilized by the liver, though it is produced by the mitochondria of the liver. Why it is not utilized by the liver? What is the reason? Because for the utilization, one enzyme is required, that is thiophorase. So that thiophorase enzyme is absent in the liver, that's why it is not utilized by the liver. So these are the two important tests. See this test, two important tests done on the urine sample, Benedict test, Rothera's test. If both the tests are positive, the diagnosis is diabetic ketoacidosis, and it is a cause of high anion gap metabolic acidosis. What do you mean by high anion gap metabolic acidosis? We will discuss this. We'll discuss this afterward. Okay. So how the pH of the blood is maintained? How the pH is maintained? What is the first line of defense? What is the second line of defense? And what is the third line of defense? As you go on the border, the BSF, Border Security Force is the first line of defense. And then the military forces, then paramilitary forces. Like that, here the blood buffer is the immediate inaction, followed by the respiratory mechanism, which is a short-term mechanism, and then the kidney, renal mechanism. Got it? First is the blood buffer system. Second one is the first is the blood buffers. These are the examples of blood buffers. Second is the respiratory mechanism, and third one is the renal mechanism, means through the kidneys. Respiratory mechanism is the short-lived, while renal mechanism is the permanent mechanism for the correction of acid-base disorder. Okay. Now blood buffers. What do you mean by buffer? The solution which raises the change in pH. The solution which raises the change in pH. And what is buffering capacity? Buffering capacity means the ml of acid, gram of acid or alkali which is required to change the pH by 1 unit of 1 liter buffer solution, that is known as buffering capacity. So blood buffer, it includes the bicarbonate, which is the important one. Second one is the phosphate buffer, and third one is the protein buffer. So bicarbonate, phosphate, and protein buffer. Of this is the major buffer system in extracellular fluid, bicarbonate buffer. Why it is major buffer system? What is the reason behind this? Because it is because of two reasons. High concentration, high bicarbonate concentration, that is known as alkali reserve. This is known as alkali reserve. And second reason is the components are under physiological control. Means CO2 by the lungs and bicarbonate by the kidneys. Do you know the Henderson-Hasselbalch equation? According to the Henderson-Hasselbalch equation, pH is equal to pKa plus log of acid, so log of base divided by acid. This is Henderson-Hasselbalch equation. So base means HCO3 and acid means H2CO3. Base means bicarbonate, acid means carbonic acid. Okay. Now the numerator, the numerator bicarbonate, it is controlled by the it is under metabolic regulation. It is controlled by the kidneys, and the carbonic acid, it is under the respiratory regulation in the form of partial pressure of CO2 by the hypoventilation, hyperventilation. If there is hyperventilation, the blowout of CO2 will occur. Hyperventilation. If it is hypoventilation, retention of CO2 will occur. Okay, in that way, respiratory mechanism will act. But this is a respiratory mechanism is a short-term mechanism, and the renal mechanism is the long-term mechanism. And body tries to maintain this ratio. The concentration of HCO3 is 20, H2CO3 is 1, and body try to maintain this ratio as 20:1. And in this way, compensation will occur. Okay, so this is the major buffer in extracellular fluid. The ratio is 20:1. The concentration of bicarbonate, it is 20. Carbonic acid is the 1. So pKa value is 6.1. More closer to the blood pH, that is 7.35 to 7.45. It is more potent. If it is closer to the pKa value, it is more potent. For example, pKa value of this phosphate buffer is 6.8. It is more potent. Okay. The bicarbonate buffer system, it is a main buffer system in the extracellular fluid because of two reasons: alkali reserve, that is high concentration, and second one is it is under the physiological control. Phosphate buffer, it is major intracellular buffer system. The ratio of 4:1. Ratio of 4:1. pKa value is 6.8. It is more potent because pKa value is nearer to the body pH. That's why it is more potent in the intracellular environment. And protein buffer, it is mainly because of albumin and hemoglobin. In hemoglobin, the histidine imidazole group, the imidazole group of histidine is act as a buffer system. Okay. So this is in yesterday. In last session, we end the session with this diagram. Okay, this is a very important diagram for diagnosis of acidosis and alkalosis. First, look for the pH. If it is below, it is acidosis. If it is above 7.45, it is alkalosis. Look for the bicarbonate level. Below 22, it is metabolic acidosis. Above 28, it is metabolic alkalosis. Okay. During my first year, almost all my classmates use your notes, sir. That too in Xerox form. Okay, thank you everyone. Thank you SR Malik. So PCO2. So the PCO2 normal range is 35 to 45 mmHg. Okay. So less than 35 indicates the respiratory alkalosis. Alkalosis, acid decrease means alkalosis. The PCO2 increased means the acidosis, respiratory acidosis. So these are the causes. Metabolic acidosis, the causes are, it is divided into two main types. Metabolic acidosis, it is divided into two main types. That is high anion gap metabolic acidosis and the normal anion gap metabolic acidosis. We'll discuss that. So diabetic ketoacidosis, renal tubular acidosis, lactic acidosis, organic aciduria, renal failure, diarrhea. These are the causes of metabolic acidosis. Metabolic alkalosis causes are omitting, upper GI tract obstruction, that is pyloric stenosis, upper GI tract obstruction, alkaline drug, antacids, Cushing syndrome, adrenal tumor. These are the causes of metabolic alkalosis. Respiratory acidosis means whenever there is retention of CO2, that causes respiratory acidosis, means obstructive airway diseases, emphysema, asthma, pneumonia, and paralysis of respiratory muscle as in narcotics and sedatives, that causes the respiratory acidosis. Then respiratory alkalosis occurs in hyperventilation. The alkalosis will occur. High altitude, hypoxia, congestive heart failure, anxiety, fever, septicemia, and meningitis. Okay. What is the primary defect in metabolic acidosis? Decrease in the bicarbonate level. The acids, they are produced in the body, and bicarbonate is used to neutralize these acids. That's why there is metabolic acidosis. Okay, metabolic alkalosis primary defect is increase in the bicarbonate level. Respiratory acidosis, the increase in the partial pressure of CO2. Respiratory alkalosis, decrease in the partial pressure of CO2. So anion gap, discuss the anion gap. Remember the mnemonic. What is the mnemonic? Why there is anion gap? It is a difference between measured cation. Anion gap is equal to measured cation. Cations mainly the sodium plus potassium minus bicarbonate plus chloride. It is a difference between measured anion and it is measured cation and measured anion. It is because of unmeasured. It is because of unmeasured anions. And which contributes to the unmeasured anions? PSPO. PSPO fan. Don't you know the PSPO fan? Okay, so PSPO, it is contributed by unmeasured anions are phosphates, proteins, phosphates, sulfate, proteins, and organic anions. These contributes to the unmeasured anions. The normal range is 8 to 18 millimole per liter. Average 12. Average 12. So there are causes of high anion gap metabolic acidosis and normal anion gap metabolic acidosis, and this is very, very important. High anion gap. So that is known as high anion gap metabolic acidosis. The causes includes diabetic ketoacidosis, lactic acidosis, then renal failure, then organic acidureas, amino acid ureas, and aspirin, high dose of aspirin. These are the causes for high anion gap metabolic acidosis. And what are the causes of normal anion gap metabolic acidosis? Normal anion gap. This is important MCQ. This is very, very important in the MCQ. Normal anion gap metabolic acidosis. This can be asked in the MCQ in the pediatric, in medicine and biochemistry. So normal anion gap, it is diarrhea. Remember this, diarrhea causes the normal anion gap metabolic acidosis. This is important MCQ. Okay, then renal tubular acidosis 1, 2 and 4. Renal tubular acidosis. Then the fistula. These are the causes of normal anion gap metabolic acidosis. Okay, this is high anion gap metabolic acidosis. So this is all about the acid base disorders. Now we'll move towards the PDF. PDF is available on the MedEd app. Okay, PDF of the previous session and also of this session will be available on MedEd app. Okay, so a 31-year-old mother delivered premature baby at 34 weeks of gestation. Baby cried well after the birth. All reflexes were normal, but 3 days, this is important, 3 days after birth, mother observed yellow skin and eyes of the baby. On blood examination, indirect bilirubin, this is also important, indirect bilirubin levels was found to be 11 milligram per deciliter. What is your probable diagnosis? Yes, think about this. What is your probable diagnosis? See, premature baby. Then on the 3rd day after the birth, mother observed yellow skin and eyes. Examination, indirect bilirubin raised and that was found out to be 11 milligram per deciliter. Which type of jaundice? Which type of jaundice it is? Yes. So C, it is a neonatal physiological jaundice. And why it is neonatal physiological jaundice? Gilbert syndrome, Vikas, it is not Gilbert syndrome, because Gilbert syndrome, see, in this syndrome, the bilirubin raised up to 4 milligram per dl. This is the characteristic feature, up to 4, beyond 4, not beyond 4. Okay. Yes, it is physiological jaundice. Okay. Rajat, Bhavna, it is physiological jaundice. Now, why it is physiological jaundice? If jaundice appear after the second day, means on the third day to fifth day after the birth, it is known as neonatal physiological jaundice. If it is within 24 hours, it is pathological jaundice. Within 24 hours after birth, it is known as pathological jaundice. This is neonatal physiological jaundice. What is the reason for this? The reason for the neonatal physiological jaundice is increased hemolysis, rapid destruction of RBCs, and immature liver system. Please don't delete these videos after the session completed. Session 1 is already there on YouTube. Okay. Rest of the FMGE acceleration videos has been deleted from YouTube. So because of some technical problem, they were deleted. But the anatomy session will be conducted after all these videos. Okay. So be on the MedEd app or be on the YouTube MedEd. Okay. So the videos and the PDF will be available. All videos for this FMGE Accelerate series, they are freely available on the YouTube channel, and the PDF is available on the MedEd app. Okay. But because of some technical issue, the anatomy video of the Pradeep Pawar sir, it is deleted, but the session of anatomy was there. It will be there on I don't know the exact date, but after the completion of all the subject, anatomy session will be there. Okay. So Pradeep Pawar sir will rock there. Okay. So 3 to 5 days, the jaundice appear. It is because of increased hemolysis and immature hepatic system. Immature hepatic system to conjugate means decrease activity of glucuronil transferase. This is the reason. Transferase. This is the reason why there is jaundice on third day of life. Okay. Why there is jaundice on the third day of life. Now, in this type of neonatal physiological jaundice, the bilirubin may goes up to 14 or 15 milligram per deciliter, but rarely or sometime it goes above the 15 milligram per deciliter. Okay. So up to 14 or 15 milligram per deciliter bilirubin will go, and in some cases it will go above 15. What is the treatment for this neonatal physiological jaundice? Phototherapy is given. Phototherapy. What is the reason for phototherapy? It converts the bilirubin. Into the photoisomer, the water soluble photoisomers, lumirubin. It is converted into lumirubin or other water soluble photoisomer. When blue light is given, when the light, it is 420 to 500 nanometer, blue light is given, it is converted into lumirubin and it is excreted through the urine. That decreases the bilirubin level. That's why phototherapy is given. And the phenobarbital is also given if it is not responding to the phototherapy. And that is the reason. So why the sun rays, when the this is the reason because of which the neonates or the infants, they are exposed to the early morning sunlight after the birth. Okay, this is the reason. So it converts bilirubin into photoisomer, which is excreted in the urine. So phototherapy is important here in the neonatal physiological jaundice. Okay. Now the fourth question, a 63-year-old man came to hospital. A 63-year-old man came to hospital with complaint of abdominal pain, pruritus, and yellow colored urine. Abdominal pain, pruritus, and yellow color urine. On laboratory investigation, SGPT 81 international unit, OT it is 72 international unit, SGPT 81, SGOT 72, alkaline phosphatase 1286 international unit per liter. Direct bilirubin 18 and indirect bilirubin 2.1. Direct bilirubin 18 and indirect bilirubin. Try to think about the answers in your mind or write it in the comment box. Okay, what is your probable diagnosis? So see here, slight increase in the SGPT activity, slight increase in the SGOT activity. There is marked increase in the alkaline phosphatase activity. There is increase in the direct bilirubin. Okay. So what is the normal range for the bilirubin? Total, direct, indirect. Total bilirubin is up to 1.1 milligram per dl. Direct it is 0.42, sorry, it is 0.2 to 0.4 milligram per deciliter. Indirect it is 0.2 to 0.7 milligram per dl. Milligram per dl. Okay. So these are the normal range. Here there is increase in the direct bilirubin. There is increase in the alkaline phosphatase, mark increase in the alkaline phosphatase activity. Bhavna Sharma, option B is the correct option here, obstructive jaundice. The answer here is obstructive jaundice. It is obstructive jaundice. Okay. Now for differentiating between these hemolytic and obstructive jaundice, hemolytic, obstructive and hepatic jaundice, there are some tests. Okay, Fauchet test and Hayes sulfur test. These are the important tests done in first year on the urine sample. Fauchet test and the Hayes sulfur test. All of you know the Hayes sulfur test. It is very easy to do and very easy to perform. That's why it is a favorite test for all the students. It is favorite test for all the students. Okay. So wait. Fauchet test. Okay. In Fauchet test, we add magnesium sulfate and barium chloride. We add magnesium sulfate and barium chloride. There is formation of barium sulfate. There is formation of barium sulfate. And bilirubin, it is given by the bile pigment, bilirubin and biliverdin. Bilirubin get adsorbed. Bilirubin get adsorbed on this barium sulfate. Bilirubin adsorb. Okay, and it will retain on the filter paper. We filter this, and this is the difficult test for the first year student, this test, Fauchet test. Okay, so we add magnesium sulfate and barium chloride. There is formation of barium sulfate, and bilirubin get adsorbed on this barium sulfate. And when we add the Fauchet reagent, when we add the reagent, that is Fauchet reagent, it will give you the green color, that is known as pista green color or green color. Pista green color. That will give you pista green color. So green color precipitate on the filter paper indicates the presence of bile pigment, means indicate the presence of bilirubin and biliverdin in the urine. And it is typically positive in the obstructive jaundice. Also it is positive in the when the in hepatic jaundice, when the micro obstruction is present. So when micro obstruction is present, bile salt is also positive in the hepatic jaundice, and the bile pigments are also positive. Okay. H sulfur test. Take a test tube, take two test tube, one for urine, one for the water, and sprinkle the sulfur powder above it. So if powder sink to the bottom of the test tube, bile salts present. It indicates the presence of bile salts. So what are the bile salts? These are the sodium and potassium salts of glycocolate and taurocolate. So Fauchet test and H sulfur test, it is positive in the obstructive jaundice, and if in hepatic jaundice, if obstruction is present, hepatic jaundice, if micro obstructions are present, micro obstruction is present, it is positive. Okay. Okay, understood, sir. Go ahead. SD, yes. So this is the difference between hemolytic, hepatic, and obstructive jaundice. See, in the hemolytic jaundice, all the enzymes, they are normal. All the enzymes, they are normal. SGOT, SGPT, alkaline phosphatase, ALP, gamma glutamyl transferase, 5 nucleotidase. All these enzymes are normal in hemolytic jaundice. Okay. While in hepatic jaundice, there is marked increase in the SGOT, SGPT, and slight increase in the ALP level. Slight increase in the ALP level. These are slightly increased. These are the obstructive enzymes, alkaline phosphatase, GGT, and the 5' nucleotidase. And in obstructive jaundice, this is slight increase in the SGOT, SGPT, but there is marked increase in the alkaline phosphatase activity. Why in obstructive jaundice alkaline phosphatase activity increases? What is the reason behind that? It is ectoenzyme. It is an ectoenzyme. Ecto means it is present on cell surface. It is present on surface of biliary canaliculi. And whenever there is obstruction to the flow of bile, the bile regurgitates and it irritates the biliary epithelium and causes the release of this alkaline phosphatase into a serum. So alkaline phosphatase activity marked increase along with the gamma glutamyl transferase and 5' nucleotidase. They are increased. They indicates the obstructive pathology. So these enzymes are increased in the obstructive jaundice. Now this, see, and this is also known as Vandenberg reaction. You may get a question on Vandenberg reaction. Okay, direct positive, indirect positive, and biphasic. Biphasic means both the type of bilirubin are present. Biphasic means both, as in hepatic jaundice, both present, direct and indirect. So it is biphasic. Okay. The direct bilirubin reacts immediately with the diazo reagent. That's why it is known as direct positive. And indirect bilirubin needs solubilizer to become the test positive. So it is known as indirect. Okay. And biphasic means both. Okay. So in hemolytic jaundice, indirect bilirubin or unconjugated bilirubin increases. In hepatic, both the type of bilirubin increases. And in obstructive jaundice, the direct bilirubin increases much more as compared to the indirect bilirubin. This is the classical test, urinary urobilinogen. It is present. It is done by the Ehrlich test. Ehrlich test. It is positive in the hemolytic jaundice, while it is absent in the obstructive jaundice. It is absent in the hepatic jaundice if there is micro obstruction. And the urine bilirubin, biliverdin, they are absent in the hemolytic jaundice, but they are present in the obstructive jaundice. Okay, there is dark colored stool in the hemolytic jaundice, while the pale colored stool in the obstructive jaundice. Now coming to the discussion of these different types of hyperbilirubinemia, these are very, very important and frequently asked questions. Different types of congenital hyperbilirubinemia. So see, unconjugated, increase in the indirect bilirubin increase. These are, and this is direct. Direct, the mnemonic is DR, direct. The causes are Dubin-Johnson and Rotor syndrome. Dubin-Johnson, Rotor syndrome, causes of direct hyperbilirubinemia or causes of conjugated hyperbilirubinemia. Dubin-Johnson, Rotor syndrome. Now the mutation is very, very important. This is due to mutation in the MRP2, multidrug resistant protein 2. Mutation in MRP2. Rotor syndrome, it is due to mutation in organic anion transporter 1B1 and 1B3. Organic anion transporter 1B1 and 1B3 mutation. I will tell you the role of these proteins also. Gilbert disease, then unconjugated hyperbilirubinemia, two disorders, Crigler-Najjar syndrome and the Gilbert, Okay. Crigler-Najjar is of two types. The complete deficiency, that is type 1, complete deficiency, and type 2, the some activity is retained. Some activity of this is retained in the type 2. Okay. Gilbert disease, it is autosomal dominant, and there is retention of activity of UDP glucuronil transferase. Some activity is present also here in Gilbert, but it is autosomal dominant. Okay. Now MRP2, wait, it is present or not, just wait. So there are 3 steps in the bilirubin metabolism. First step is the uptake by the hepatocyte. This is the first step. Second step is the conjugation in the hepatocyte. And third one is the, first one is the uptake by the hepatocyte. Second one is the conjugation, and third one is the secretion into bile canaliculi. Okay, these are the 3 steps. First one is the uptake, second one is the conjugation by the UDP glucuronil transferase, and third one is the secretion into bile. Secretion into bile. These are the 3 steps. Of these 3 steps, this one is the rate limiting step, secretion into bile canaliculi. It is with the help of active transport. Secretion into bile canaliculi, it is with the help of active transport. And this requires MRP2. This is a MRP2 is the carrier protein which is required for the active transport. So mutation in the MRP2 causes the Dubin-Johnson syndrome. And what is the role of this organic anion transporter 1B1 and 1B3? It is required for the reuptake of conjugated bilirubin by the hepatocyte. It is required for reuptake of conjugated bilirubin. Reuptake of conjugated bilirubin by hepatocytes. Okay. Crigler-Najjar, there is complete deficiency of UDP glucuronil transferase. It is a fatal disorder. Bilirubin goes above 20 milligram per deciliter, and it causes kernicterus. Why bilirubin is toxic to the brain? Yes, why bilirubin is toxic to the brain? So recollect the uncoupler topic. Yes. Unconjugated bilirubin, high levels of unconjugated bilirubin, it is uncoupler. So there is production of heat without production of ATP. So that's why it causes toxic effect in the brain, bilirubin. Okay. So kernicterus, when it goes above the 20 milligram per deciliter. This is a milder form, partial deficiency of UDP glucuronil transferase. This is it is a milder form, and bilirubin is below 20 milligram per deciliter. Here the bilirubin level goes up to 4 milligram per deciliter. Okay. In Dubin-Johnson syndrome, that is black colored liver due to deposition of black pigment, thought to be metabolites of epinephrine, metanephrine. That's why black colored liver is there. Okay. So this is about the conjugated hyperbilirubinemia, congenital hyperbilirubinemia. Dubin-Johnson rotor, direct. Dubin-Johnson rotor, indirect. Crigler-Najjar, Gilbert. Okay. Enzyme deficient in von Gurk disease. Now we are jumping from the Jaundice to the glycogen storage disorders. Okay, jaundice to the glycogen storage disorder. Enzyme deficient in von Gogh disease is, which enzyme is deficient in von Gogh disease? Yes. Option D, glucose 6 phosphatase. Yes, correct. Bhavna, correct. Glucose 6 phosphatase. What are the MCQs related with this? Wait. What are the MCQs related with the glucose 6 phosphatase? Try to recollect the MCQs related with glucose 6 phosphatase. What is the location? It is present in endoplasmic reticulum. What is the role of glucose 6 phosphatase? It causes the conversion of glucose 6 phosphate to glucose. Okay. It is an important enzyme of which pathway? It belongs to two pathway. Which two pathway? One is the glycogenolysis, end stage of glycogenolysis, and gluconeogenesis. Not okay. Thank you. Okay. So glycogenolysis and gluconeogenesis. Okay. So this enzyme is common to both pathway, glycogenolysis and gluconeogenesis. Okay. So wait. Enzyme deficient in von Gogh disease is glucose 6 phosphatase. Whenever there is deficiency of glucose 6 phosphatase occur, there is accumulation of glycogen occurs in the liver. It causes hepatomegaly. It causes hepatomegaly. It causes the doll-like faces. Doll-like face. It causes hepatomegaly, doll-like faces. Then it causes, there is hyper increase in the lipids, hyperlipidemia. Then increase in the uric acid. Then increase in the lactate. Increase in the lactate level. So there is increase in the lipid, increase in the uric acid, increase in the lactate level, and glucose level decreases. So glucose level decreases. Okay. So hepatomegaly, doll-like faces because of fatty cheeks, hypoglycemia, hyperlipidemia, increased uric acid, increased lactic acid. These are the features of von Gogh's disease. Coming to the next question. This question was asked in the recent NEET PG entrance examination. A 7-year-old child came to the OPD with complaints of easy fatigability. The mother also complained that the kid is active after the meal and is extremely hungry and tired in between the meals. Liver biopsy shows no glycogen accumulation. What is the most likely enzyme deficient? It is a glycogen storage disorder, but there is no deposition of glycogen in the liver. Okay. So in branching enzyme defect, there is accumulation of glycogen. Debranching enzyme, there is also accumulation of glycogen. Glucose 6 phosphatase deficiency, there is liver involved. In glucose 6 phosphatase deficiency, there is no spleen, no splenomegaly, no spleen is not involved, and the muscle is not involved because this enzyme is absent in the muscle. Okay, here answer is D. This was from the recent NEET PG entrance examination. Here answer is D, glycogen synthase. The disorder is known as type 0 glycogen storage disorder. Type 0 glycogen storage disorder type 0 due to the deficiency of glycogen synthase. Due to the deficiency of glycogen synthase. Okay. So we'll discuss the disorders. Wait. Next question. A 7-year-old child came with complaints of excessive fatigue and muscle pain after playing in the school. This is also a MCQ from the recent NEET exam. Okay. Blood investigation were done immediately after the exercise and the result shows low glucose and lactate level. Which of the most probable diagnosis in this child? Which of the following is the most probable diagnosis in this child? Excessive fatigue and muscle involvement is there. pain after playing in the school. So exercise intolerance is the classical feature of which disorder? Here answer is McArdle's disease. Why it is McArdle's disease? There is involvement of muscle. There is involvement of muscle. Exercise intolerance is there. Okay. In von Gog's disease, liver is involved, muscle is not involved. Cory's disease, it is due to deficiency of debranching enzyme, CD, debranching enzyme. And it is characterized by progressive liver involvement. There is increase in the transaminase level in the Cory's disease. In the Pompey's disease, it is due to acid maltase defect. It mainly involves the heart. And the death of the child occurs earlier, at early age. So it is not Pompey's disease, 7-year-old child. It is not Pompey's disease. Here, the McArdle disease, the features of McArdle disease, it is due to muscle. It is muscle glycogen phosphorylase deficiency, involves the muscle. Typical feature is exercise intolerance. The second wind phenomenon. What do you mean by second wind phenomenon? If you take a pause after some exercise, you can resume your activity. That is known as second wind phenomenon. And because of myoglobin because of rhabdomyolysis, there is myoglobin and passage of burgundy color urine in McArdle disease. So these are the features of McArdle's disease. So this is a chart of glycogen storage disorder. Type 0 glycogen storage disorder due to defect in glycogen synthase. It is not stored. Glycogen is not deposited in the liver. So there is no hepatomegaly. There is hypoglycemia in between the meal in the deficiency of glycogen synthase. The von Gog's disease, it is due to glucose 6-phosphatase defect. There is no spleen involvement and there is no muscle involvement. So fasting hypoglycemia, increase in the TG, hyperuricemia, lactic acidosis and hepatomegaly. These are the symptoms of von Gog's disease. Then type 1B is also there. There is recurrent bacterial infection and the neutropenia will be there in the type 1B glycogen storage disorder. Okay, which is defect in the transport of glucose 6-phosphate. Then type 2 is the Pompey's disease. It mainly involves the heart and the death occurred due to the cardiac involvement. Death of the child occurred because of cardiac involvement, Pompey's disease. Okay, it is because of lysosomal acid maltase defect. Then type 3 is the Cory's disease, as it is C. There is deficiency of debranching enzyme CD and ABCD. Anderson disease branching enzyme, Cory's disease debranching enzyme. Okay, so in the Cory's disease, there is defect in debranching enzyme. There is accumulation of the branch glycogen, that is the accumulation of dextrin, and it lead to the progressive liver cirrhosis. There is increase in the transaminase level in this Cory's disease. Anderson, there is Anderson's disease, defect in the branching enzyme, hepatosplenomegaly, cirrhosis liver and death at early age occurs. Then McArdle's disease, muscle involvement, muscle phosphorylase defect, exercise intolerance, second wind phenomenon, and the excretion of myoglobin in urine occurs in McArdle's disease. In type 6 Hirsch's disease, liver phosphorylase is deficient and hepatomegaly and fasting hypoglycemia is there. So there are two important disorders which involves the muscle, mainly the Pompey's disease. In the Pompey's disease, there is involvement of the muscle. In the McArdle disease, there is involvement of muscle. One is the Tharoi's disease, there is also muscle involvement. Okay, rest of the diseases, there is involvement of the liver. Okay. Identify the condition. This is also a question from recent NEET exam. Okay, identify the condition. Here, look here. So it is whether it is scurvy, rickets, phrinoderma or pellagra. Remove one by one. Scurvy, What are the typical manifestations of scurvy? Gum bleeding, petechial hemorrhages, carbotic rosary, and in the advanced cases, pseudo paralysis because of joint effusion and arthritis. Rickets. Rickets. What are the features? We'll discuss rickets at the last, because here answer is rickets. Okay. Phrynoderma, it is, yes, B is the correct answer. Phrynoderma, it is due to vitamin A deficiency. It is due to deficiency of essential fatty acid. Essential fatty acids. So horny eruptions on the posterior aspects of the arm, that is causes toad-like skin appearance, or phrynoderma. Okay, phrynoderma. Pellagra, classical 3Ds: diarrhea, dementia, and dermatitis. Diarrhea, dementia, and dermatitis. Here it is showing the bow legs, curved legs, bow legs. So weight-bearing bones curved because of defective mineralization. It is a feature of rickets. What are the features of rickets? The features or symptoms includes craniotabes. What do you mean by craniotabes? The ping pong ball like appearance skull. When you press the skull, it will like a ping pong ball. Okay, so that is craniotabes. Then the open fontanelles, delayed closure of fontanelles, frontal bossing will be there. Then when he start crawling, this weight bearing bones, means the during the crawling, this wrist becomes widened, and when he start walking, these weight bearing bones becomes bowed. And another features are Harrison's sulcus, rachitic rosary. Rachitic rosary means prominent costochondral junctions. Harrison's sulcus means there is transverse groove along the insertion of the diaphragm. Okay, so these are the features of rickets. Vitamin D deficiency in children causes the rickets, while in adults it causes the osteomalacia. Okay, which of the following explain the role of sun in the vitamin D metabolism? Read the options. Yes, ricket, rosary, bow leg, knock knees, frontal bossing. Correct. PPP. Which of the following explain the role of sun in vitamin D metabolism? Conversion of cholecalciferol to 25-hydroxy cholecalciferol? No. Conversion of 10 to 25-hydroxy cholecalciferol to calcitriol? No. Conversion of 25-hydroxy cholecalciferol to 24-25-dihydroxy cholecalciferol? No. Conversion of 7-dehydrocholesterol to cholecalciferol? What is answer here? The answer is conversion of 7-dehydrocholesterol to cholecalciferol. Okay, so see, 7-dehydrocholesterol. 7-dehydrocholesterol is present in the epidermis. 7-dehydrocholesterol, it is present in the epidermis. It is present in the stratum corneum layer of epidermis. Stratum corneum layer of epidermis, and on exposure to UV rays, UVB rays, this 7-dehydrocholesterol is converted into UVB rays by the sunlight. It is converted into cholecalciferol. Cholecalciferol. Now by the liver, by the enzyme 25-hydroxylase, by 25-hydroxylase, it is converted into 25-hydroxy cholecalciferol, and by the 1-alpha hydroxylase in the kidneys, it is converted into 1,25-dihydroxy cholecalciferol. So it is known as calcitriol. That is active form of vitamin D, vitamin D3. It is known as active form of vitamin D3. Cholecalciferol, 1,25-dihydroxy cholecalciferol, that is calcitriol. So what is the role of the sun rays? By UVB light, 7-dehydrocholesterol is converted into cholecalciferol. Okay, this is the step. In which of the following disorder ATP7A protein is deficient? So this is the topic from the cell membrane. Also this is a topic from the copper metabolism. Okay, so in which of the following disorder ATP7A protein is deficient? It is Menkes Kinky hair syndrome. Menkes kinky hair syndrome. So what are the different mutation in the different disorders? Wait. ABC proteins. ABC proteins. Okay. It includes ABC proteins includes ABCA1, ATP binding cassette transporter A1, ABCC2, that is also known as MRP2, then ATP7A, then ATP7B, and CFTR gene. So these are the important ATP binding cassette transporter proteins. The mutation in ABCA1 lead to the disorder that is known as Tangiers disease. It is known as Tangiers disease, characterized by orange tonsils. ABCA1. What is the role of ABCA1? Incorporation of cholesterol into HDL. Incorporation of cholesterol into HDL. So it causes Tangiers disease. ABCC2 or MRP2. Just now we discussed this. The defect in MRP2 or ABCC2 causes the Dubin-Johnson syndrome. Dubin-Johnson syndrome. Okay, ATP7A mutation, 7A, A comes first, so it causes Menkes disease. It causes Menkes disease. ATP7B mutation, it causes Wilson's disease. Wilson's disease we already discussed in the yesterday lecture. Wilson's disease is hepatolenticular degeneration due to mutation in ATP7B. Okay, CFTR, cystic fibrosis transmembrane regulator gene. Mutation causes the cystic fibrosis. Cystic fibrosis. So these are the important disorders related with this ATP binding cassette transporter proteins. See now, Menkes disease and Wilson's disease. This A come first, that's why Menkes first, B second, that's why Wilson's second. So in Menkes disease, there is decrease in absorption of copper from the intestine, lead to the defect, that is due to the copper deficiency, there is defect in the lysyl oxidase, and that causes the manifestation. Like lysyl oxidase, it is important for collagen cross-linking and strengthening of the collagen. Collagen cross-linking and strengthening of the collagen, lysyl oxidase in Menkes disease. That's why it is characterized by mental retardation, then hypopigmentation, then brittle hair, easily pluckable brittle hair, kinky hair. Okay, Menkes disease, and involvement of large vessels because it affects the lysyl oxidase. Hypopigmentation because it affects the tyrosinase. Menkes disease. Wilson's disease, there is excess of copper and decrease in the ceruloplasmin because incorporation into ceruloplasmin is decreased. And because copper excretion in bile is decreased, there is accumulation of copper that causes the KF ring, that causes the hepatomegaly, that causes the involvement of lenticular nucleus of the brain, that causes the sunflower cataract, and the manifestations, that is hepatolenticular degeneration. Sunflower cataract, KF ring in the decimate membrane of the cornea, that is golden brown colored ring, then the involvement of liver and involvement of brain in Wilson's disease. A patient is having fatigue and weakness. On examination, his hemoglobin was low. Iron levels were also low. Patient noted that his wound healing is delayed since last 1 year. Which vitamin deficiency is possible in this patient? Wound healing. We already discussed this yesterday. Answer this question. What are the vitamins or minerals they are responsible for wound healing? The 3 important things are required for the wound healing. First one is the vitamin C. Second one is the zinc. And third one is the hyaluronic acid. Zinc, vitamin C and hyaluronic acid, these are required for the wound healing. Okay, fatigue and weakness, hemoglobin was low. Hemoglobin was low is possible. Here answer is vitamin C. Why vitamin C is the answer? Because vitamin C is required for the conversion of ferric into ferrous form and absorption of iron. It is required for the absorption of iron. Vitamin C increases the absorption of iron. So this is related with this point. Okay. Vitamin A, it is related with the vision. B12 with the megaloblastic and anemia and subacute combined degeneration of spinal cord. Vitamin B2 is related with a riboflavinosis, that is angular stomatitis, chiliosis, glossitis, magenta tongue, seborrheic dermatitis and all. Okay. And circumcorneal vascularization, keratitis and all. Okay. So here answer is vitamin C. If the percentage of thymine residue in DNA is 28%, calculate this. What is the percentage of cytosine? It follows the Chargaff's rules. What is Chargaff's rules? According to this rule, purines are equal to pyrimidines. Purines are equal to pyrimidines. If number of purines means if the percentage of thymine residue in DNA is 28%, if it is 28%, thymine is 28, means adenine, thymine pair with the adenine. Okay, so adenine is 28, so it becomes 56%. Remaining is 44%. Answer is D, 22%. Yes, correct. 22%. PPP. Okay. Yes. Zenmode, 22%. Okay. So remaining is 44%, which is divided into 22 plus 22. So what is the percentage of cytosine? Cytosine 22% and the guanine it is 22%. So it is Chargaff's rules, that is number of purines are equal to pyrimidines. See, these are the two DNA strands. According to Watson and Crick model, there are two strands of the DNA. DNA is a double helical structure, one in 5' to 3', other one is the 3' to 5' direction. So this 5' phosphate is free and the 3' hydroxyl group is free. That's why it is 5' to 3' direction. Okay, this is ribose, this is nitrogen base and this is phosphate. Ribose, nitrogen base and phosphate. The bond between two adjacent nitrogen bases, it is hydrogen bond. It is two bonds between adenine and thymine, while three in between the guanine and cytosine. These are known as hydrogen bonds. While the bond between the two nucleotide, it is known as 3', 5' phosphodiester linkage. It is known as 3', 5' phosphodiester linkage. Okay. So this is the different types of DNA. We'll skip that. DNA packing is done by which of the following? Yes, answer this question. DNA packaging is done by which of the following? Histone, glycoprotein, nucleic acid or adenine. DNA is negatively charged because of 5' phosphate and 5' phosphate which is negatively charged. So DNA is negatively charged. It is packed with the positively charged histone proteins. It is with the positively charged histone proteins. So this is histone octamer. There is formation of histone octamer. Around this histone octamer, DNA get wrapped. There are around 1.75 tons of DNA around this histone octamer. 1.75 ton. That includes near about 145 to 150 base pairs. And linker DNA, it is with the H1 histone. This is the along with the linker DNA. So it includes near about 30 base pairs. So 1.75 ton of DNA around the histone octamer. Okay. So the major and minor grooves, the histone proteins, they are associated with the DNA in the major and minor grooves. So there are 5 levels of organization of the DNA. First is the DNA, that is 2 nanometer. Then the nucleosome, which gives bits on string appearance in the microscopy, that is 10 nanometer chromatin fibril, 10 nanometer chromatin fibril, which appears like bits on string appearance in the microscope. Then this 10 nanometer is converted into 30 nanometer fiber by further coiling of this 10 nanometer fiber. It is converted into 30 nanometer fiber. Then this 39 nanometer fiber, it is converted into non-condensed nuclear scaffold associated protein, which is about 300 nanometer. Then it is converted into condensed form. And then it is converted into chromosome. Metaphase chromosome, which is near about 1400 nanometer. So there are 5 levels of organization. So DNA, it is wrapped up around the nucleosome. So this is octamer, histone octamer. This is linker DNA. Then it is again folded to form a 30 nanometer fibril, which is converted into 300 and 700 nanometer non-condensed and condensed nuclear scaffold associated protein, and then it is converted into metaphase chromosome. Okay. So histone proteins, they are positively charged because of arginine and lysine. What is the bond between nitrogen bases of 2 DNA strand? It is hydrogen bonds. Okay. So because adenine form bond with the thymine and cytosine form bond with the guanine. Because when you see the 3-dimensional structure, only adenine can base pair with the thymine with the help of 2 hydrogen bonds, and cytosine with the guanine with the help of 3 hydrogen bonds. At physiological pH, DNA molecules are negatively charged. Okay. The bases which are present in human DNA. Which bases are present in human DNA? So it is, there is no uracil. So see the option. So adenine, guanine, cytosine, and thymine. What mechanism is seen in xeroderma pigmentosum? So these are the types of DNA repair. Answer is the B. Okay. Nucleotide excision repair. Correct. Nucleotide excision repair. It is not mismatch repair. It is nucleotide excision repair. Now see, base excision repair is there when there is damaged base or whenever there is creation of a basic site. It is related with mute YH associated polyposis. Okay. Then nucleotide excision repair, it is related with disorder that is known as xeroderma pigmentosum. This is a disorder in which the multiple freckles on sun exposed part of the body. Okay, multiple freckles on sun exposed part of the body. This is a UV light induced pyrimidine dimer formation. Xeroderma pigmentosum is the condition in which thymine dimer formation occurs that causes bulky lesion, and whenever there is defect in this, it causes whenever there is defect in the nucleotide excision repair which repair this lesion, this causes xeroderma pigmentosum. Mismatch repair is associated with hereditary non-polyposis colorectal cancer, also known as Lynch syndrome. Hereditary non-polyposis colorectal cancer, that is HNPCC, hereditary non-polyposis colorectal cancer. Homologous recombination It is a repair when there is double strand break, or whenever it is not chloisma. Okay, in xeroderma pigmentosum it is not chloisma, that is the different thing. Okay, xeroderma pigmentosum is multiple freckles on sun exposed part of body, like it is multiple moles, multiple small moles on the sun exposed part of the body. It is not related with the chloisma. Chloisma is the different thing and it is resistant to. Okay, homologous recombination is there whenever there is double strand break or break in the single strand, or the cross links in between the two strand, or cross link in between the single strand. So homologous recombination is there. If there is defective homologous recombination, it can lead to the Bloom syndrome, or ataxia telangiectasia. Then susceptibility to breast cancer, BRCA1 and BRCA2 gene. So these are the disorders related with the homologous recombination. The most common repair mechanism in double strand break, single strand break, or cross linkage is the non-homologous end joining. So these are the different mechanism, these are the different disorders, and these are the different repair mechanism. Okay, mismatch repair is operative whenever there is mismatch base. Normally adenine is against the thymine, adenine and thymine. If A is base pair with the C, this is known as mismatch base. This is repaired by the mismatch mechanism. Okay. So this is easy question. Start codon is AUG. AUG is the start codon. The UAA, UAG, and UGA, these are the stop codons. Okay. Now UGA, it can be recoded for the selenocysteine. It can be recoded for the selenocysteine, and UAG, it can be recoded for the pyrrolysine. Okay. UGA, it is code for the tryptophan in mitochondria. It codes for the tryptophan in mitochondria. All of you know the genetic code. They are universal, unambiguous, comma-less, non-punctuating, and degeneracy. They are triplet codon. They are comma-less, non-punctuating, non-overlapping. They are degenerative, and they are unambiguous. Okay, means what is the meaning of degeneracy of genetic code? It is degeneracy of genetic code means third base pair in the mRNA, it is ignored by the tRNA. So that's why that is known as the different amino acids can be coded by the, means one amino acid can be coded by the different codon, that is known as degeneracy of genetic code. Which of the following is an inhibitor of complex 1 of electron transport chain? Complex 1 of electron transport chain. Which of the following inhibitor? What are the inhibitors of complex 1 here? Answer is rotenone. Oligomycin, it is inhibitor of oxidative phosphorylation. Cyanide inhibits the complex 4 of electron transport chain. Rotenone is the inhibitor of complex 1. Malonate inhibits the complex 2 of electron transport chain. Succinate dehydrogenase. It inhibits the succinate dehydrogenase. So, see, the complex 1 means NADH to FMN through iron sulfur protein. It is coenzyme Q. So this NADH coenzyme Q oxidoreductase is the complex 1. Okay. This is complex 1. The complex 1 of electron transport chain, it is inhibited by pyridine, gonithidine, Guanethidine, rotenone, which is a fish poison, amobarbitol, secobarbital. These are the inhibitors of complex 1 of electron transport chain. Then complex 2, succinate dehydrogenase. It is inhibited by malonate. It is inhibited by malonate. And from this, there is FADS2 and FADS2 to the coenzyme Q. It is inhibited by, that is, chelating agent TTFA, trifluoroacetone, okay, and the carboxyl. These are the inhibitor of complex 2. Malonate, TTFA and carboxyl. These are the inhibitor of complex 2. Then coenzyme Q to the complex 3. To the complex 3. Complex 3, it is inhibited by the antimycin, British anti-levisite, fenformin, and the complex 4 through cytochrome C. It is complex 4, that is complex 4. It is inhibited by the gases cyanide, carbon monoxide, hydrogen sulfide and azide. These are the inhibitors of complex 4. So complex 1 is the PG react, pyridine, guanethidine, rotenone, amobarbitol, secobarbital. PG react mnemonic. So complex 2 TMC, TTFA, carboxyl, malonate. Complex 3 is the anti-BP, antimycin, British anti-levisite, fenformin. And the complex 4, all gases cyanide, carbon monoxide, hydrogen sulfide and azide. Okay. In an isolated mitochondria in a medium containing succinate, fumarate, ADP and inorganic phosphates and ATP were produced. Later a compound was added and oxidative phosphorylation was decreased. Oxidative phosphorylation was decreased. What's that compound? What's that compound? Okay. See, 2,4-dinitrophenol is an uncoupler. What is the role of uncoupler? It increases the permeability of inner mitochondrial membrane and the gradient, proton gradient will not develop there. So it acts as a uncoupler. Antimycin, it is inhibitor of electron transport chain. It is complex 3 inhibitor. Rotenone is the inhibitor of complex 1. Complex 1 of electron transport chain. Here only one left, that is the oligomycin, which is the inhibitor of oxidative phosphorylation. This oligomycin inhibit the FO subunit. This is FO. O for oligomycin. And F1. 1 means it was the first factor which was isolated from the mitochondria. That's why the name is given F1. So F1, FO. So O means its inhibition by the oligomycin. So it inhibits the oxidative phosphorylation. We'll discuss with the diagram this part. So here answer is oligomycin. See, this is inner mitochondrial membrane. This is inner mitochondrial membrane. This is complex 1 of electron transport chain. This is complex 1 of electron transport chain. Then this is complex 2 of electron transport chain. Then complex 3 and complex 4. Okay. Complex 4 of electron transport chain. And then we will draw the ATP synthesis. So this is inner mitochondrial membrane. This is matrix side. Matrix side. This is membrane. Inner membrane. This is space, intermembrane space. Intermembrane space. Okay. Now This is complex 1, 2, 3, 4. Complex 1, 2, 3, and 4. So there is transfer of protons. Whenever there is transfer of electron from complex 1, electron are transferred to coenzyme Q, and coenzyme Q2 it is transferred to the complex 3. From complex 3 it is transferred to the cytochrome C, and some cytochrome C to the complex 4. It is accepted by the oxygen and it is converted into water molecule. It is converted into water molecule. Okay, so these are mobile component. Coenzyme Q is the lipid but mobile. Cytochrome C is the protein and mobile component of electron transport chain. It is not fixed. The position of these components, they are not fixed in the electron transport chain. Okay, now while transfer of electron, there is the energy release from this. It is 12 kilocalorie energy release from the complex 1, neighbor about 12 kilocalorie from complex 3, and 10 kilocalorie from the complex 4 during the transfer of electron. When the transfer of electron occurs, simultaneously it is associated with the pumping of protons across the membrane. So 4 protons are pumped out from the complex 1, 4 protons are pumped out from the complex 3, and 2 protons are pumped out from the complex 4. So no protons are pumped out from the complex 2 because it is not a transmembrane protein. This is the first point. Second point, the energy released during the transfer of electron, it is less to pump the proton outside the membrane. So these are the two reasons. That's why this 2 is not related with the pumping of protons outside the membrane. It is pumping of protons outside the membrane. So just change the site, wait. Pumping of proton occurs from inside of the mitochondria to the outside. This is the intermembrane space. This is the intermembrane space. Intermembrane space, and this is matrix. Okay, so protons are pumped out of the membrane, and as protons are pumped out of the membrane into the intermembrane space, there is generation of proton gradient. Outside the membrane, there is generation of proton gradient. This is explained by the chemiosmotic hypothesis proposed by the Peter Michel, that is responsible for generation of positive outside and negative inside the inner mitochondrial membrane that generates the proton gradient. It can be compared with the hydroelectricity. You know, for the electricity production from the water, first we make the reservoir. So water is stored, and from high point the water will release, and this water will fall on the turbine, and that rotates the turbine. So in that way, here is the generation of proton gradient, and this membrane is impermeable to these protons, and only point from where it can enters into the mitochondria is through the ATP synthase. So this is the FO unit of the ATP synthase, and F1 unit of the ATP synthase. This is gamma handle of F1 unit. To this, the different alpha and beta subunits are attached. So this is the only entry point from which the hydrogen ion can enter. So oligomycin inhibit this FO subunit. While entering through this FO subunit, it rotates the gamma handle that causes the conformational change in the beta subunit of ATP synthase. This model, the rotary model proposed by the Paul Boyer, it is the world's smallest molecular motor. When there is protons accumulated in the intermembrane space, it moves through this FO subunit. It causes rotation of gamma handle that causes the change in the or conformational change in the beta subunit of ATP complex, and that is responsible for ATP formation via the binding change mechanism. This is known as chemiosmotic hypothesis proposed by the Peter Michel. For the synthesis, so 10 protons are pumped out, 10 protons. That will give you 2.5 ATPs from the NADH. That will give you 2.5 ATP from the NADH. For synthesis of 1 ATP, 4 protons are required. 4 protons are required. Actually, 3 protons are required and 1 is required for the transport. So 4 protons are required for the 1 ATP synthesis. So 2.5 ATP is given by the NADH, and FADH2 will give 1.5 ATP. Why? Because FADH2 will start from here. This is succinate dehydrogenase. This is FADH2, and that is transferred from this complex 2 to the coenzyme Q, and then to 3, then cytochrome C, then to 4, and then water molecule. So it will bypass the first step. That's why only 6 protons are pumped out. It will give 1.5 ATP. Okay. So this is the chemiosmotic hypothesis. This is a model, rotary model proposed by the Paul Boyer. Okay, these are the different complexes 1, 2, 3, 4. Question number 21. Transport of ADP into and ATP out of mitochondria is inhibited by ATP into. Try to answer this question. Transport of ADP into and ATP out of mitochondria is inhibited by. It is inhibited by this atractyloside. Oligomycin inhibit the FO subunit. Okay, cyanide is the inhibitor of the complex 4. Okay, so here answer is atractyloside. Which of the following block the flow of electron through the FO complex? FO, it is not F0, it is FO, okay, complex of ATP synthase. Electron flow through the FO complex of ATP synthase. It is oligomycin. Okay. Complex 4 of electron transport chain, it is inhibited by the gases. So cyanide, carbon monoxide, then azide and hydrogen sulfide, they inhibit the complex 4 of electron transport chain. Thermogenin is present in mitochondria. Thermogenin is uncoupler. Thermogenin is present in mitochondria. It is particularly important in the newborn and hibernating animals. Whether I am visible, audible to you? Yes. Wait. Just wait. Here answer is mitochondria. Thermogenin is present in mitochondria. It is physiological uncoupler. It is particularly important during the hibernation in the hibernating animals, and it is important for prevention of hypothermia in the neonates. It is important for prevention of hypothermia. What are the physiological uncouplers? Names? Physiological uncouplers. It includes thermogenin, then long chain free fatty acids, unconjugated bilirubin, and thyroxine. While chemical uncouplers, it includes chemical uncouplers that include 2,4-dinitrophenol, dinitrocresol, then pentachlorophenol, then some drugs are there, that is valinomycin, gramicidine. These are the drugs which are potassium ionophores. Yes, visible and audible. Thank you. So these are the potassium ionophores, valinomycin, gramicidin, and these potassium ionophore disrupt the gradient across the membrane. That's why they act as an chemical uncoupler. What is the mechanism of action of chemical uncoupler? Uncoupler, see this. Just wait. They disrupt this gradient. They increases the permeability of this membrane. So they disrupt the proton gradient which is developed across the membrane. So there is no passage of hydrogen ion through this FO complex, and there is no generation of ATP. Only heat will be produced. LDH enzyme is present in LDH, lactate dehydrogenase. It is present in cytosol. What are the marker enzymes in different for different cellular organelles? What are the different marker enzymes for cytoplasm? What is the marker enzyme for cytoplasm? What is for mitochondria? What is for endoplasmic reticulum? What is for lysosomes? Then what is marker enzyme for cytoplasm? It is lactate dehydrogenase. Marker enzyme for mitochondria, inner mitochondrial membrane, it is ATP synthase. ATP synthase. Marker enzyme for endoplasmic reticulum, it is glucose 6 phosphatase. Then lysosome, it is cathepsin. Cathepsin. Then Golgi apparatus. Golgi apparatus, it is galactosyl transferase. Galactosyl transferase. These are the important marker enzymes for different cellular organelles. Okay. De novo synthesis of fatty acid requires which coenzyme? It requires which coenzyme is required? It requires NADPH for all reductive biosynthesis. For example, steroid synthesis, cholesterol synthesis, fatty acid synthesis, NADPH is required. And what are the sources for NADPH? There are three important sources. One is the HMP shunt, two enzymes of the HMP shunt. Second one is the malic enzyme, that is NADP malate dehydrogenase, malic enzyme. And third one is the cytosolic isocitrate dehydrogenase. These are the three important sources for the NADPH. Answer A is the correct answer. HMP shunt, two enzymes, glucose 6 phosphate dehydrogenase, and second one is phosphogluconate dehydrogenase. These are the two important enzymes which gives the NADPH in the HMP shunt. Okay. So two important regulatory enzymes. One is the acetyl-CoA carboxylase, which requires biotin as a cofactor, and second one is the fatty acid synthase complex. It includes reductase, two reductase. For that two reductase reaction, NADPH is required. Nitric, this is frequently asked question. It is a top rated MCQ for any entrance examination. FMGE, NEET PG entrance examination, and INICET. Nitric oxide is derived from, here answer is yes, arginine. So arginine with the nitric oxide synthase, it will give you citrulline and nitric oxide. This is important. It is smooth muscle relaxant, and it will act through cyclic GMP as a second messenger. It will act through cyclic GMP. So citrulline and nitric oxide. This nitric oxide synthase requires 5 coenzymes. It requires 5 coenzymes. Now name the 5 coenzymes. Heme is required. Then FAD is required. FMN is required. Then tetrahydrobiopterin, it is required, and NADPH. NADPH. These are the 5 coenzymes required for the nitric oxide synthase system. Arginine will give citrulline plus nitric oxide. Okay. Cholesterol is synthesized from acetyl coenzyme A. What is the rate limiting step? in the cholesterol synthesis, HMG-CoA reductase is the rate limiting step. HMG coenzyme A reductase. What is the location of this enzyme? HMG-CoA reductase, it is present in endoplasmic reticulum. This is a rate limiting step which converts the hydroxymethylglutaryl coenzyme A to mevalonate. It converts HMG-CoA to the mevalonate, HMG-CoA reductase. Okay, it is present in endoplasmic reticulum. It is a rate limiting step, and through various steps there is synthesis of cholesterol. It is regulated by two important mechanisms. One is by the dephosphorylation and phosphorylation, and second one is the feedback mechanism. Second one is the feedback mechanism or feedback regulation, which is at the genetic level. Yes, statins are important and related to this topic. So we are discussing the statins. Wait. So HMG coenzyme is converted into mevalonate. Mevalonate is converted into cholesterol. This is the rate limiting step. HMG-CoA reductase. It requires NADPH. It is present in endoplasmic reticulum, regulated. It is active in the dephosphorylated state, and it is favored by the insulin. Dephosphorylated state is favored by the insulin. Again, it is regulated by the feedback regulation at the genetic level via the transcription factors. Now the drug which act against these are the statins group of drugs. Statins, they inhibit the HMG-CoA reductase. These statins, they are structurally similar to that of HMG coenzyme A, and they compete for the active site of HMG-CoA reductase. So statins, they reduces the cholesterol level. Statins, simvastatin, atorvastatin, lovastatin, they decreases the cholesterol level. Competitive inhibition. Which of the following is required for transport of endogenous TG? HDL, it is required for the reverse transport of cholesterol. Reverse transport of cholesterol. This is from liver to peripheral tissues. Cholesterol transport. VLDL, transport of TG. Transport of endogenous TG. And chylomicron, it is transport of exogenous TG. From intestine to liver, it is through the chylomicron. So answer is here exogenous TG. Endogenous TG, transport of endogenous TG, the answer is VLDL. Answer is C, VLDL. VLDL is required for transport of endogenous TG from liver to the tissues, while the intestinal absorption by the dietary TG, it is carried to the liver via the chylomicron. This is exogenous TG. Okay, transport of exogenous TG. These are the different apoproteins and their functions. Protein part of apoprotein, protein part of lipoprotein. No, see, lipids are insoluble. So for carrying the lipid, proteins are required. So lipids are associated with protein, that is known as lipoprotein. Lipid with protein, they are known as lipoprotein. And protein part of lipoprotein is known as apoprotein. So these are the apoproteins. Okay, what is the function of B48? It is important in chylomicron. P100, it is VLDL, IDL, LDL. There is P100 present. Okay. C1 inhibit the cholesterol ester transfer protein. C2, it activates the lipoprotein lipase. This is important, remember this. C2 activates lipoprotein lipase. C3 inhibit lipoprotein lipase. ApoA1, this is again important, activates the LCAT, lecithin cholesterol acyl transferase. ApoA1 activates LCAT. ApoA2 inhibits the lipoprotein lipase. ApoA5, it promotes the lipoprotein lipase mediated lipolysis. And ApoE, it is a receptor for remnant VLDL, and it is receptor for the chylomicron remnant in the liver. So it is important for uptake of chylomicron and VLDL in the liver. ApoE. Okay. So here ApoB48 and B100, These are example of RNA editing. RNA editing. They are synthesized from one gene. One gene produces different proteins. That is known as RNA editing. One is produced in the intestine. This is produced in the intestine. This is produced in the liver. This is produced in the liver. This is known as RNA editing. So in only 48% is synthesized in the intestine because of premature termination of protein synthesis. Here cytidine deaminase causes the conversion of cytidine into uracil, and the CAA, it is turned into UAA, and UAA is the stop codon, and it only in the intestine only 48% is synthesized. That is known as ApoB48. That is known as ApoB48. Okay, so this is example of RNA editing. From the single gene, two proteins are produced, that is ApoB48 and ApoB100. This is in the intestine, this is in the liver. Here only 48% is synthesized because of premature termination of or premature truncation of protein synthesis, because the cytidine deaminase converts this cytosine into uracil, and in place of CAA there is UAA, which act as a stop codon, and only 48% of polypeptide is synthesized. That is known as ApoB48. Okay, so these are the roles of different apoproteins. These are the disorders. Now this topic is very, very important for your FMGE exam, also INICET and PG entrance examination. Now what to be remembered from this table? See, type 1 is the familial chylomicronemia. This is, remember the defect for this 1 and 2. Remember the defect for these 2. Familial chylomicronemia, these are the hyperlipoproteinemia. This is known as Fredrickson classification of hyperlipoproteinemia. So lipoprotein lipase defect or ApoC2 defect. Okay, familial chylomicronemia. Remember this only, LPL deficiency or ApoC2 defect. Lipoprotein accumulated is chylomicron, and VLDL, the lipid accumulated is TG. Whenever there is accumulation of TG, see here TG is accumulated, here TG is accumulated. So hypertriglyceridemia is there, that is prone for the pancreatitis. So there is risk of pancreatitis. There is risk of pancreatitis when TG accumulated. See, 1 and 5, it is related with TG, and 2A, it is related with cholesterol. 2A, it is related with cholesterol. These are hyperlipoproteinemia. Just wait. Type 1 and type 5, there is increased triglyceride level. In type 1 and type 5, there is increased triglyceride level. As there is increased triglyceride level, they are more prone for pancreatitis. More prone for pancreatitis. And they will manifest as eruptive xanthomas. Eruptive xanthomas. They will manifest as eruptive xanthomas. Type 2A, there is increase in the cholesterol. There is increase in the cholesterol. So there is tendon xanthoma that involves the tendons. So tendon xanthoma, and there is risk of coronary artery diseases, atherosclerosis. Atherosclerosis. That is type 2A. Okay. And remember the type 3, it is ApoE defect, and there is accumulation of remnant. So there is accumulation of remnant VLDL and remnant chylomicron. Okay. So, and type 4 and 5, type 4 and 5, there is mixed response. See, type 1 familial chylomicronemia, there is increase, the deficiency of LPL, lipoprotein lipase. Chylomicron and VLDL increases, there is increase in the TG. This 2A is important, that is familial hypercholesterolemia. LDL receptor defect or ApoB defect, there is accumulation of LDL and cholesterol. So there is chances of tendon xanthomas and there is risk of coronary artery diseases. And statins were given, or statins are given in the treatment of these disorders. Statins. Okay. Then the third, it is familial beta lipoproteinemia, or it is also known as broad beta disease. Broad beta disease. There is ApoE defect. You can convert this 3 into E. It is ApoE defect. Okay, it is ApoE defect. There is accumulation of remnant VLDL and chylomicron. Remnant. Okay, so that leads to the xanthoma and atherosclerosis. In the type 4, what should be remembered? This point should be remembered in the type 4. It is responsible for glucose tolerance. It is responsible for hyperinsulinemia. It is responsible for coronary artery diseases. It is important in the alcoholism, obesity, and diabetes mellitus. It is associated with coronary artery diseases, alcoholism, obesity, and diabetes mellitus. There is glucose intolerance and hyperinsulinemia in the type 4. There is increase in the TG level. This A5, ApoA5 is related with lipoprotein lipase mediated lipolysis. Lipoprotein lipase mediated TG lipolysis. So depict in this 4 and 5, there is increase in the TG level. Okay. So this is hyperlipoproteinemia. Hypolipoproteinemia, 3 causes. One is the A-beta lipoproteinemia, in which the beta apoprotein synthesis decreases. That's why beta, it is present in chylomicron, it is present in VLDL, it is present in IDL, and it is present in LDL. There is decreased synthesis of all these lipoproteins because beta is not synthesized. Beta is not synthesized. Okay, Tangiers disease and fish eye disease. There is alpha lipoprotein synthesis. Alpha lipoprotein decreases. So there is decrease HDL level. Tangiers disease. Can you remember one MCQ which is related with the Tangiers disease? Related with the tonsil. Which colored tonsil in the Tangiers disease? Yes, it is orange tonsil in the Tangiers disease. Fish eye disease, it is due to the partial deficiency of lecithin cholesterol acyl transferase. Fish eye disease, it is partial deficiency of lecithin cholesterol acyl transferase, and complete deficiency is known as Norum's disease. Complete deficiency is known as, so complete deficiency of LCAT, lecithin cholesterol acyl transferase. It is known as Norum's disease. Question number 30. In case of LPL deficiency, which of the following will increase after fat-rich diet? Lipoprotein lipase deficiency. It is characterized by chylomicronemia. If chylomicron increases, it gives milky urine, milky color appearance to the serum. Okay. Which of the following will increase after the fat-rich diet? So here answer is chylomicron. Type 1 hyperlipoproteinemia is characterized by, now read carefully. Read carefully. Type 1 hyperlipoproteinemia is characterized by, type 1 means lipoprotein lipase deficiency. Now see further this. There is elevated, so this is not incorrect option. Okay. So if there is in the type 1 hyperlipoproteinemia, it is also known as chylomicronemia. It is also known as chylomicronemia. There is lipoprotein lipase defect. What is the role of lipoprotein lipase? It converts the TG into fatty acid and glycerol. So if this is defective, TG will accumulate. So elevated triglyceride in the plasma. This is the answer. A patient has multiple tendon xanthoma. This is very, very important. Whenever there is tendon xanthoma, orange tonsil. Yes, correct. Whenever there is tendon xanthoma, think about the cholesterol. Whenever there is eruptive xanthomas, think about the triglyceride. So a patient has multiple tendon xanthomas, serum cholesterol level 398 mg per deciliter and LDL 220 mg per deciliter. Okay, statins. were given to the patient, what is the diagnosis? This is type 1. This is type 1. Familial hypercholesterolemia, this is type 2. Type 2A. Pangeus, this is alpha, decrease alpha lipoprotein. Fisheye disease, there is decrease LCAT. So what is answer here? What should be answer here? It is familial hypercholesterolemia. Okay. Which of the following is cardioprotective? So HDL is known as good cholesterol. It is cardioprotective. Now I will tell you the HDL metabolism in short, not in detail, but in short. So HDL, it is produced by the liver and intestine. It is produced by the liver and intestine, HDL. It is produced as nascent discoidal HDL. It is produced as nascent discoidal HDL. This is known as nascent discoidal HDL. Okay. HDL metabolism is very, very important. There is role of different components in the HDL metabolism. The LCAT is important. Cholesterol ester transfer protein is important. Then polyunsaturated fatty acid is important. Then in polyunsaturated fatty acid, essential fatty acids, they are important. So there is role of different things in the reverse transport of cholesterol. That's why we should consume the essential fatty acids, polyunsaturated fatty acids. They are important in the reverse transport of cholesterol. Okay. So it is synthesized from the liver and intestine, particularly the proteins. This ApoA1 is only synthesized from the liver, not from the intestine. Here answer is HDL, but we are discussing the HDL metabolism. It is produced as nascent discoidal HDL, chapka hua HDL. Okay. So there is ApoA1. When it release into the serum, LCAT get attached to this. There is attachment of LCAT, lecithin cholesterol acyl transferase, ApoA1. And this ApoA1 activates this LCAT, lecithin cholesterol acyl transferase. It activates the LCAT. LCAT causes the conversion of cholesterol from the peripheral tissues. There is cholesterol in the peripheral tissues. This is cholesterol in the peripheral tissue. It is transported to the HDL with the help of different transporter. They are known as SRB1, scavenger receptor B1, or also known as ABCA1, which is defective in the Tanger's disease, ABCA1 or ABCG1 protein, ATP-binding cassette transporter G1 protein. These proteins transport the cholesterol. These proteins transport the cholesterol from tissues to the HDL. From tissues to the HDL. And the LCAT, lecithin cholesterol acyl transferase, it removes the fatty acid from the lecithin. It removes the fatty acid. Lecithin is the phospholipid. So this lecithin is made up of, this is lecithin. It is made up of glycerol, fatty acid. This is the essential fatty acid mainly. Essential fatty acid, mainly the unsaturated fatty acid. Okay. And this is the phosphate and this is choline. This is lecithin. Okay. Now this transport this unsaturated fatty acid from the C2 position of lecithin, LCAT, transfer this fatty acid from the C2 position of lecithin to this cholesterol and causes the esterification of cholesterol, and this esterified cholesterol moves to the HDL. This esterified cholesterol moves to the HDL. As it is hydrophobic. This is lipid. Cholesterol ester, this is lipid. And it is hydrophobic. It moves interior of the HDL. And that's why the HDL becomes spherical. By taking the cholesterol ester, this becomes spherical. HDL becomes spherical. By taking the cholesterol from the tissue, LCAT causes the esterification of cholesterol, and cholesterol ester attached to the HDL particle. Being the hydrophobic, it moves to the interior of the HDL particle. Now this discoidal HDL becomes the spherical one. So this is known as HDL3. HDL3. This is known as HDL3. ApoA1. This is known as HDL3. Okay. Now HDL3, it is converted into HDL2. HDL2. So HDL2 having the less cholesterol as compared to the HDL3 and high TG as compared to the cholesterol 3. How? It is with the help of cholesterol ester transfer protein. Cholesterol ester transfer protein, which transfer this cholesterol ester to VLDL, IDL and LDL. It transfers the cholesterol to this protein in exchange of the TG, in exchange of triglyceride. So triglyceride is given to the HDL, and now it becomes HDL2. So this conversion of HDL2 to HDL3 and HDL3 to HDL2 is known as HDL cycle, and it is then HDL2, it is taken up by the liver. It is then taken up by the liver. So this is in short discussion of HDL. So what is what are the different compounds required for the reverse transport of cholesterol? Lecithin is required, phospholipid. Lecithin is the phospholipid. The unsaturated fatty acid is required, means essential fatty acid is required. Then LCAT is required, ApoA1 is required. So these all are cardioprotective. Okay, so it is taken up by the liver. Which of the following is present in skeletal muscle? This is the important MCQ. All of you know this MCQ. Okay. GLUT4, GLUT8 and GLUT12. These are present in skeletal muscle, adipose tissue and heart. Skeletal muscle, adipose tissue and heart. GLUT4. Okay. So wait. GLUT4 here. There are two types of glucose transporter. A is the correct option. Two types of glucose transport. One is the sodium dependent glucose transporter. Sodium dependent glucose transporter. You know that glucose transport is dependent on the sodium. Okay, that's why in ORS along with the sodium there is glucose to increase the absorption of the sodium along with the glucose, because it is like a poem. All of you know the poem, that is Mary had a little lamb, and wherever Mary goes the lamb will follow her. Like that, wherever the sodium goes, glucose will follow the sodium, or wherever glucose goes, sodium will follow the glucose. This is known as SIMPOT. Sodium dependent glucose transporter. There are two types, 1 and 2. One is present in the intestine and renal tubules. 2 is present in the renal tubules. This is for absorption of glucose and galactose. This is for absorption of glucose only. Sodium dependent glucose transporter. These are the sodium dependent glucose transporter. Okay. Now these are the secondary. These are the examples of secondary active transport. Now the facilitated transport, there are facilitated diffusion. There are total 12 types. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Total 12 types. Of these 12 types, one, the GLUT1, GLUT1. GLUT1, it is present in brain. It is present in placenta, kidneys, brain, placenta, kidneys. Okay, GLUT1. Then it is present in RBCs. It is present in colon. Okay, GLUT1. And GLUT2, which is important, GLUT2, it is present in basolateral membrane, basolateral surface of intestine. It is present on basolateral surface of intestine. It is present on GLUT2. It is present on liver sinusoidal surface, liver sinusoid. It is present on beta cells of the pancreas. Pancreas. Okay, GLUT2. This is for the basal glucose level, to maintain the basal glucose level. This is for the glucose regulation. It is active when the glucose concentration is high. GLUT3, it is present in neuron. GLUT3, it is present in neurons. And GLUT4, it is present in GLUT4, G-L-U-T, GLUT4. It is present in skeletal muscle, adipose tissue, heart, and it is insulin dependent. Insulin dependent, GLUT4. And what is MCQ related with the GLUT5? It is responsible for transport of fructose. So remember 3F, fructose facilitated diffusion, and type 5, GLUT5. Fructose facilitated diffusion, GLUT5. Okay, so these are the important GLUT 1, 2, 3, 4. Then 4, 8 and 12, they are insulin dependent. GLUT4, GLUT8 and GLUT12, they are insulin dependent glucose transporters. Melanin is derived from which amino acid? It is from the tyrosine. What are the specialized products given by the tyrosine? Tyrosine will give you melanin. It will give you dopamine, norepinephrine, epinephrine. It will give you T3 and T4. It will give you T3 and T4. Tryptophan will give you the serotonin, melatonin. Phenylalanine will give you tyrosine, and tyrosine will give these products. Okay, alanine will give you pyruvate. So melanin is derived from which amino acid? It is from the tyrosine. Most abundant amino acid found in collagen is the, which one is found in collagen? Which one is found in collagen? Yes. Which one is the most common amino acid in the collagen? It is glycine. It is glycine. Collagen contains 30% glycine. Collagen contains 30% glycine. Collagen is made up of glycine XY. It is made up of 3 polypeptide chain. It is made up of 3 polypeptide chain. Each one contains 1000 amino acid, and that contains 30% glycine. The glycine is important. No, hydroxyproline is not the common amino acid. It is glycine. 30% glycine. Because of the smaller size, it can fit into the turns of that collagen molecule. So that's why it is very, very important, glycine. Okay, each polypeptide is composed of 1000 amino acid. The second most common amino acid after the glycine is proline. Third important is hydroxyproline. There is lysine also and hydroxylysine also, but these are the main. Glycine XY. Okay, glycine is the most common amino acid in the collagen. So extracellular matrix, it is composed of structural proteins, specialized glycoprotein and proteoglycans. Structural proteins include collagen, elastin and fibrillin. Specialized glycoprotein includes fibronectin and laminin. Proteoglycan, agrican, syndican, beta glycan, these are the different proteoglycans. They are made up of the glycosaminoglycans. This is the structure of collagen. So suppose this is glycine. So glycine XY like this. The glycine XY like this. Okay. So this is the triple helix. Each polypeptide chain is composed of 1000 amino acid, and this is quarter staggered alignment. The one polypeptide is displaced by long 1/4 of the other, so that is known as quarter staggered arrangement. So there are various steps in the collagen synthesis. First, there is formation of polypeptide. So it is, there are steps. Pre-pro-collagen is converted into pro-collagen. That is PPTC. Pre-pro-collagen, pro-collagen, tropo-collagen, collagen. Pre-pro-collagen, pro-collagen, tropo-collagen, collagen. Pre-pro-collagen is converted into pro-collagen, which is converted into tropo-collagen, which is converted into collagen. So there are various steps in the collagen formation. Pre-pro-collagen is converted into pro-collagen by removing the signal peptide, which is, signal peptide means there is signal in every peptide chain after its synthesis, which indicates, that is known as leader sequence, which target that peptide to the particular organelles where it is functional. That is known as leader sequence or signal peptide. It is removed by the signal peptidase. So signal peptidase will remove the peptide. Signal peptidase, it is removed. Okay. After the removal, it is converted into pro-collagen. Now by the then hydroxylation, vitamin C dependent hydroxylation occur. The proline and lysine, they are converted into hydroxyproline, hydroxylysine. After hydroxylation, glycosylation occur. Then sulfide bond formation occur, disulfide bond formation occur, and assembly into triple helix. This type of assembly occurs. Now in the tropocollagen, this amino terminal and carboxy terminal, they are removed with the help of amino peptidase and carboxy peptidase. So amino peptidase and carboxy peptidase removes this terminal polypeptide. Okay. Then the interchain and intrachain disulfide bond formation occur. So interchain and intrachain disulfide bond occurs. Then hydroxylation of lysine. The hydroxylation of lysine occurs with the help of lysyl oxidase. Here is the role of lysyl oxidase, which converts this lysine into hydroxylysine and hydroxylysine into the aldehydes. That is responsible for cross-linking in the collagen molecule. So lysyl oxidase is particularly important for strengthening of the collagen. It is lysyl oxidase, it is particularly important for the strengthening of the collagen. So lysyl oxidase, it is related with the copper. And this hydroxylation, it is related with the vitamin C. Hydroxylation of proline and lysine into hydroxylysine and hydroxyproline, it is vitamin C dependent. For cross-linking between the hydroxylysine and its conversion to aldehyde and aldol cross-links formation, it is dependent on copper dependent lysyl oxidase. So it is important for strengthening of the collagen cross-linking. So this is the role of lysyl oxidase. Okay, so these are the events: cleavage of signal peptide, hydroxylation and glycosylation. This is vitamin C dependent. Then formation of disulfide bond and triple helix formation, assembly of 3 chains together. Okay, then cleavage of amino and carboxyl terminal occurs. Then quarter staggered alignment. The adjacent polypeptide is displaced from the previous one by its length, quarter length, 1/4 length. Then oxidative deamination of lysine and hydroxylysine occur, which is caused by the lysyl oxidase, which is copper dependent enzyme. And then intra and interchain cross links via the ship bases and aldols occurs. And this is important for strengthening of the collagen. Okay, these are the different types of the collagen. Remember only up to 4. There are number of types of the collagen, 26, 27, 28, 29 types of the collagen. Type 1 is present in the bone, tendon and skin. 2 is present in the cartilage. 3, this is important, it is present in the elastic tissues, skin, lungs, vessels. It is important, type 3 collagen. Type 4, it is present in the glomerular basement membrane. Remember these 4 collagen. Then 7, it is present in the dermoepidermal junction. 7, type 7, it is dermoepidermal junction. Then 19 is related with the rhabdomyosarcoma cell. Then the 25th, it is related with the brain, and 26th related with the testes and ovaries. So remember first 4 and type 7. First 4 and type 7, remember. Type 1 is for the bone, type 2 for cartilage, type 3 for the elastic tissues, type 4 for the glomerular basement membrane, and type 7 for the dermoepidermal junctions. Okay. So these are the different types of the collagen. Now we'll discuss the important disorders related with the collagen. So see, hyperextensibility of skin and abnormal tissue fragility and increased joint mobility. तो कुछ बच्चे रहते हैं ना, वो ऐसे पूरा हाथ ऐसा कर देते. ओके, हर एक को रहता है, ऐसा जरूरी नहीं है. बट हाइपर एक्सटेंसिबिलिटी ऑफ स्किन, एबनॉर्मल टिश्यू फ्रैजिलिटी एंड इंक्रीज joint mobility is a feature of which disorder? It is a feature of which disorder? It is Ehlers-Danlos syndrome. It is Ehlers-Danlos syndrome. Menkes disease, there is kinky hair. There is kinky hair in the Menkes disease. In the epidermolysis bullosa, there is blistering skin lesions, blisters. Okay, osteogenesis imperfecta, there is bone involvement of sclera. Here there is hypermobility of the joint and hyperextensible skin. That is Ehlers-Danlos syndrome. It is Ehlers-Danlos syndrome. It is defect in the type 3 collagen. There are many types, but mostly it is due to the defect in type 3 collagen. Brittle bones and abnormal sclera, blue sclera, are the features of brittle bones, type 1 collagen, involvement of type 1 collagen. The disease is here osteogenesis imperfecta. The disease is osteogenesis imperfecta. Okay. Type 1 collagen. Skin breaks and blisters as a result of minor trauma is due to mutation in collagen 7A1. Okay, type 7 collagen. Affecting the structures of type 7 collagen is found in, it is epidermolysis bullosa. It is epidermolysis bullosa. Blistering skin lesion and damage to the skin occur even after the minor trauma. Which is the, we'll discuss the disorders. Wait. We'll discuss the disorders. So collagen related disorders, there are 7 disorders which are important. One is osteogenesis imperfecta. Osteogenesis imperfecta. Second one is the Ehlers-Danlos syndrome. Ehlers-Danlos syndrome. Third one is the epidermolysis bullosa. Then Alport syndrome. Then fifth one is the chondrodysplasia. Then sixth one is the scurvy. And seventh one is the Menkes disease. These are the 7 important disorders related with the collagen. Okay, in osteogenesis imperfecta, there is involvement of the type 1 collagen. There is involvement of bone, characterized by brittle bone and blue sclera. Ehlers-Danlos syndrome, there is hyperextensible skin and hypermobility of the joints due to defect in the type 3 collagen. Type 3 collagen. Epidermolysis bullosa, there is blistering skin lesion and can damage with the minor trauma. So it is due to the defect in the type 7 collagen which is present at the dermoepidermal junctions. Alport syndrome, it involves the kidney. It causes hematuria and renal involvement. So it is due to the type 4, defect in the type 4 collagen. Alport syndrome. Chondrodysplasia, it is due to the defect in the type 2 which is present in the cartilage. Type 2. There is dwarfism. In the chondrodysplasia, there is short-limbed dwarfism. It is known as it is a dominant condition and it causes short-limbed dwarfism. Okay. Scurvy, all of you know, bleeding gums, petechial hemorrhagic tendency, and joint effusion is there in the scurvy because it is important for the hydroxylation reaction. It is important for formation of hydroxyproline and hydroxylysine by the hydroxylation, which is vitamin C dependent process. So scurvy. Then means it is important in the collagen formation. Menkes disease, the lysyl oxidase defect. Lysyl oxidase, it is important for the deamination of the hydroxylysine and it is important for collagen cross-linking and strengthening of the collagen. In Menkes disease, there is kinky hair. There is kinky hair due to the mutation in the ATP7A gene. The copper deficiency affect the lysyl oxidase. So these are the different disorders related with the collagen. Okay. Which is a product of purine metabolism. So this is a product of purine metabolism. Okay, this is protein metabolism. Xanthine, it is an intermediate in the uric acid formation. Beta alanine is the end product of pyrimidine metabolism. Myocardium normally utilizes fatty acid. Okay, the brain utilizes glucose. Brain utilizes glucose in the fed state, in the fasting, in the starvation and prolonged starvation. During the prolonged starvation, brain utilizes ketone bodies. Here, brain started utilizing the ketone bodies, mainly the glucose. Glucose is the main source, but it started utilizing the ketone body. Fatty acid, it is an important source of energy for the heart. It is for the heart and for the many tissues, also the skeletal muscle. Okay. So what is the preferred fuel? Just wait. What is the preferred fuel? Here, for the brain, the preferred fuel is the glucose. For the brain, it is glucose. RBC, though no other option is available, it is glucose. Preferred fuel for the RBC is the glucose. For the heart, it is fatty acid. For the liver, in the well-fed state, it is amino acid. For the skeletal muscle, it is glucose. It is glucose, glycogen, source of energy, source of fuel, glucose, glycogen. Okay, these are the important source. In the prolonged starvation, during the prolonged starvation, brain utilizes ketone bodies. RBC utilizes glucose. There is no other option for the RBC. Heart utilizes ketone bodies. Liver utilizes fatty acids. Liver never utilizes ketone bodies. And skeletal muscle also, it utilizes fatty acid, ketone bodies. Okay. Glucose can be synthesized from all except, this is the easy question. It is related with the gluconeogenesis. All of you know the substrate for gluconeogenesis: glucogenic amino acids, glycerol, lactate, and propionyl coenzyme A, that is odd chain fatty acid. Acetyl coenzyme A is never a substrate for gluconeogenesis. Glycosaminoglycan present in cornea. Here, see, there are two correct options. One is the keratin sulfate, one is the dermatan sulfate. For maintaining the corneal transparency, the keratin sulfate one is important and dermatan sulfate is also important. But here, preferred answer is keratin sulfate. Keratin sulfate is important for maintaining the transparency of the cornea. mucopolysaccharide that does not contain uronic acid residue is, see, the mucopolysaccharides or heteropolysaccharide, they are repeating disaccharide unit. They are composed of amino sugar plus uronic acid. So they are repeating disaccharide unit. They are made up of amino sugar plus uronic acid. But only the keratan sulfate is there which do not contain the uronic acid. It contains N-acetyl glucosamine and galactose keratan sulfate. Okay, so this is the composition of keratan sulfate, N-acetyl glucosamine and galactose. All other contain, those who started with the H, it contain N-acetyl glucosamine and it contain N-acetyl glucosamine. The chondroitin sulfate, dermatan sulfate, it contain N-acetyl galactosamine. Okay, all contain D-glucuronic acid except keratan sulfate, it does not contain D-glucuronic acid, and the dermatan sulfate, it contain L-iduronic acid. The heparin contain both D-glucuronic acid, L-iduronic acid. Okay, so we'll discuss the important functions. First one is the hyaluronic acid. It is important, it is present in synovial fluid and vitreous humor of the eye, and it is important in shock absorbent, lubricant. These are negatively charged, so negative repulse each other and they act as a shock absorbent, they act as a lubricant. Then it is important for the wound repair. It is important in cell migration. Then the chondroitin sulfate, it is present in cartilage, walls. No, it is present in the cartilage. It is important along with the hyaluronic acid. Chondroitin sulfate is responsible for compressibility of the cartilage. Along with the hyaluronic acid. Then dermatan sulfate, it is present in skin, vessels and walls. So it is important for maintaining the structure of this compound. Dermatan sulfate. Heparin is an anticoagulant. Then hyaluronic acid, heparan sulfate. This is very, very important. Heparan sulfate. The functions of heparan sulfate are very important. It has three important functions. First, heparan sulfate, it is important for negative charge of glomerular basement membrane. It gives negative charge to the glomerular basement membrane. That's why the albumin normally does not crosses the glomerular basement membrane. Means it is responsible for charge selectiveness of glomerular basement membrane. Second, it is important for anchoring the lipoprotein lipase to capillary endothelium. Anchoring the lipoprotein lipase enzyme to the capillary endothelium. And third important is, it is important for cell adhesion, and it is present in synaptic vesicles. Okay. Then keratan sulfate, it is important for maintaining the transparency of cornea. So this is all about the today's session. We discussed the glycogen storage disorder, we discussed the hyperlipoproteinemia, we discussed the HDL metabolism, we discussed the collagen. Now how collagen is related with vitamin C, how it is related with the copper, how lysyl oxidase then the hydroxylase, they are interconnected to each other. So Menkes disease, lysyl oxidase defect, scurvy, vitamin C deficiency, defect in the hydroxylation, defect in the defective collagen synthesis. We discussed the disorders, various disorders related with the collagen. We discussed the some points related with the genetics. And now, how will you prepare for the biochemistry? Just prepare in an integrated way, in integration with the other topic and integration with the other subject. It should be prepared. Okay. So thank you all of you. Thank you very much.